Thank you for the kind introduction. And let's go. My disclosures, I have some book royalties, 2 new companies that I'm happy to have the conflict after 20 years and no one else doing this. Finney, Volek, and I were found, well, who else is going to do this? So we're helping companies grow, which I think is great. I'm going to pull up a couple highlights from the literature and then highlights from my clinical practice at Duke. Now that mice have done this and live longer, I think humans can. Mice fed a keto diet. So the objective of this study, published in 2017, was to take mice that had been 12 years old, or 12 months old, and so they purchased the mice and then put them on either an 89% fat diet, a 70% fat diet, or a 65% carbohydrate diet. And the median lifespans following these mice for the ketogenic was 1,000 days, low carb 943, and then the control days 886. It was significantly different between the ketogenic and control, and it was a 13% longer lifespan. There were fewer cancers, better mice mental function, however you measure that. And the conclusion basically said, the study demonstrates that energy-controlled high-fat diets are not detrimental to health, but rather a ketogenic diet extends lifespan and slows mice or age-related decline in physiologic function in mice. So now that we have a mice study saying this, it's fine for us, which I think all of the usual, this is one of the reasons why the medical community and research community has not followed, because they're supposed to do mice studies first. So actually I think this is an important study because many animal researchers and many clinical researchers won't do the studies until the animal studies are done. So a lot of the human stuff we've already done really doesn't apply to them. Interestingly, the cell metabolism now has an abstract pictorial infographic, and basically so that here's the little mouse on the ketogenic diet. They were randomized at a month, and they basically lived 13% longer. Better motor function, memory, less tumors. Pretty good. Another important study that was published this last year was the Hallberg study, entitled Effectiveness and Safety of a Novel Care Model for the Management of Type 2 Diabetes at a Year, an open-labeled, non-randomized controlled study. In this study, at 1 year, they took 262 people with type 2 diabetes. The average BMI was 40 and Caucasian. This might sound familiar because you heard from the principal investigator, first author just a moment ago. But for those of you who did not hear, they actually taught a ketogenic diet through classes or web-based program, and the goal was nutritional ketosis for a year or longer. The outcomes were blood ketones, body weights, and an app was used. This is again, the intervention was pretty intensive. They knew the ketone levels, and the hemoglobin A1C reduced from 7.6 to 6.3% with lots of medication reduction. The body weight change was down 14 kilograms at a year. Insulin therapy was reduced or eliminated in 94% of the 78 subjects who were on insulin. This is a very important study. Please read it if you're interested in the effects of ketogenic diet on diabetes. I'm not even going to mention the usual care group because nothing changed. But the other thing that these studies are now elucidating are what are the real world ketone levels that you can expect. I get these questions all the time. My ketone level is this, ketone level is that, what's normal? Well, among people with diabetes, here at 10 weeks is the distribution of blood ketones as published in the McKenzie trial, which was the 10-week data from this clinical study. And you can see that it's a skewed distribution where most people have a blood beta-hydroxybutyrate under 1. And so if you're wondering what is ketosis, I keep saying we don't really know the formal distributions. We're learning, but these were folks with diabetes, which actually might not reflect the distributions among people without diabetes. In the Hallberg paper, they did show the distribution of the mean beta-hydroxybutyrate over time. And again, this is a great way to verify adherence to the program, that they were in ketosis, another great strength of this clinical study. Now, not quite such a good study on the low-carb diet was one you may have heard of recently, entitled "The Effect of a Low-Fat versus Low-Carb Diet on 12-Month Weight Loss in Overweight Adults and the Association with Genotype Pattern or Insulin Secretion," otherwise known as the DIET-FITS randomized clinical trial. The average BMI was 33, 60% were Caucasian, 20% Hispanic. Diabetes was excluded. And the weight change with these two different diets was, over 12 months, was 5.3 kilograms for the low fat, low carb 6.0 kilograms. It was not statistically significant. So you may have heard in the news, low carb and low fat, no difference. Well, let's look a little closer at the fourth bullet. Low carb was defined as 30% of the daily caloric intake, or this is what was achieved, or a 90 to 120 gram carbohydrate per day diet. So it wasn't a keto study. And so you look at at 3 months here on the far left, 3 month the carbohydrate grams, and in red the healthy low fat diet achieved a 205 grams per day. Healthy low carb diet achieved a 96.6 gram per day diet at 3 months. So you can't really call this a keto diet. So how did they come to this? And knowing Christopher Gardner, who never, to my knowledge, stepped foot in a clinic of a keto diet practitioner, but he's in charge of a big study. You look at the yellow. So participants were instructed to reduce intake of total fat or digestible carbs to 20 grams per day during the first 8 weeks. So it's kind of like the symmetrical. We'll make it even kind of neat. So the symmetry with the fat and the carbs. And then we'll let people add back fat or carbs in increments of 5 to 15 grams per day, per week, until they reached the lowest level of intake they believed could be maintained indefinitely. How many of you thought in the first day you could do this forever? I mean, or the first week, first 3 months. So basically they asked and knowing, having done clinical trials with equipoise, meaning I don't really know what's better or not, I'm not going to really say, you can do it. I'll say, okay, let's give you back an apple a day. I mean, okay, you can't keep the carb restriction low. Okay, let's give you back just half a slice of bread and then this. So anyway, so the teaching, you can see why they gradually got out of the keto range, and why, when you look on the grams per day on the y-axis, calories per day on the x-axis, these are all the different diets, and this is how I'd like you to think of it in scientific terms. When you think of a low carbohydrate diet, in our paper in 2007, we said 50 grams or below was a low carb ketogenic diet. Problem is the ketone threshold changes. Are we talking about blood or urine or breath or maybe one day skin? But here's what the study, DIET-FITS randomized trial studied. So they came out with a low fat and low carb, which really wasn't a low carb, not anywhere near a low carb ketogenic diet. But the Hallberg study was right on target. Okay, so if you're going to compare these studies, you have to understand the level of carbohydrate was very different that was achieved by the different groups in different cities, different methodologies. And let's just look at the kilograms lost over the year. It was 5.3 for low fat, 6.0 for low carb, and 12.0 for the keto, and they had diabetes too. So if you want something that really works, why not you choose a keto diet with those studies, the highlights over this last year. The Duke Lifestyle Medicine Clinic was established in 2006, and it uses the low-carb, high-fat diet or keto diet as a first-line therapy. We thought at that time, Dr. Yancey and I, who had done a lot of the clinical trials on low-carb and low-fat, that the evidence was there, basically, to start using this in the clinic. In our estimation, the studies were done like a drug approval for FDA. Of course, you don't have to have a diet approval at FDA, thus all of the nutritional confusion. Anyone can write a diet book, right? So we're open up we have a new EHR over the last few years and the electronic health record, and we've seen over 4,000 patients in 28,000 clinic visits. This is insurance pay. That's what kept me having a salary over the last few years. Yes, you can do it within an insurance system. Patient characteristics on average, the average age is 50.5 years, 74% female, 53% Caucasian, 41% African American in North Carolina, where this is based, at Duke University. The average BMI, 40.5 kilograms per meter squared. And the payer mix, those who are paying the bills, about 50% private, 50% public, Medicare and Medicaid being seen. And over the last 2 years, we have better data. That's the last 5 years. I don't know how that happened. Maybe it was the 2 a.m. effect. Over the last 5 years, we've seen 2,000 patients and 26,000 pounds lost in a Q quality improvement analysis. I'm going to redo that and want to get this publication quality, meaning we have to do it again and make sure we're somewhat near the same result. Just want to, show you what. Oh, thank you. Yep. Let me show a couple patients over the last year, some highlights, showing what you can do beyond diabetes. This was a 70-year-old woman who came to me now 5 years ago for weight loss. She had had a Roux-en-Y gastric bypass in 1984, seeking out the world's expert in Greenville, North Carolina at the time. She had a revision in 2002, and then basically the obesity medicine or the bariatric surgeons said, we've done all we can do, go on home. So she was at BMI of 34, weight of 260 pounds, and given her personality, she said, no way, I want more. So she sought out an obesity medicine specialist at Duke, and over the next few years, using low-carb, high-fat diets, a little bit of diuretic and potassium with this is medically monitored. We helped her go down to her high school weight and BMI of 23.8 over the ensuing few years. And we estimate it was 50 visits, so it's about every month, and about $4,000 to the insurance company. She got the copay, and that's when you compare the surgical costs of the Roux-en-Y and the revisions, and the surgeons they're kind of happy to do revisions. I was on a panel with another surgeon, and we had a difficult case. And he asked to see the internal anatomy, to see what revision he'd do. And I got up and I said, what is the patient eating? And so when you're a surgeon, you have surgical approaches. When you're a lifestyle guy, doctor, you have a lifestyle. I asked what people are eating. Now, it's just a different way to do it. Now, some people talk about grass-fed beef, grass-fed butter, I can't afford it. The carb quantity is more important than the food quality for just weight loss or just achieving great results. If you want to go the extra mile, I don't know. I'm still waiting should I have not taught this guy to just eat at McDonald's and lose 100 pounds? Or should I have waited until he could have afforded grass-fed beef and going to the farm? Well, he never would have, okay? So anyway, we meet people where they are. He started the LCHF instruction and really didn't get it going until he figured out, over a few months that he could just eat at McDonald's off the dollar menu. Now, not to push any particular fast food, but if you're thinking of in low carbohydrate terms, you're basically just saying don't eat the carbohydrates where you're eating. Make sure you're getting great nutrition, mainly the proteins and animal-based proteins. I worry less about nutritional issues. So he was marching along, losing 15 pounds a month. This is body weight in 50-pound increments on the y-axis and years on the x-axis. Then he went down to spring break in North Carolina. People go down to Daytona Beach. He drank some carbs. He didn't lose weight, but he didn't gain weight. He was happy. Drank some beer. Yeah. And so he's back in Durham losing weight on basically a fast food diet only. Pretty cool. Yeah, but let's get to the medical things. I'm one of those general internists, who thought I could treat everyone, and now I realize I can't, and I became an obesity medicine specialist, but now I have that attitude, I can treat anyone with obesity medicine. So Here's a patient, 73-year-old white male with congestive heart failure, CHF, chronic kidney disease, CKD, diabetes mellitus, DM, an EF or ejection fraction of 25%. He was full of fluid, edema in his legs, was basically on death's door. They put a left ventricular assist device in him, which is basically a pump outside the heart with two tubes, one that goes from the left ventricle to the aorta. When you listen to the heart, there's a and in some people they don't even have a heartbeat, so there's no lub-dub. It's just a but he had a lub-dub, that kind of thing. Pretty sick guy, and no one's going to touch it. He can't even get a heart transplant because he weighs too much. So yeah, what happens? He gets sent to me. So we put him on the low-carb, high-fat diet or a keto diet. We include a sodium restriction, a water restriction, and a vitamin K restriction because he's taken warfarin or Coumadin, which is an anticoagulant. It's okay. You just monitor these things, and you don't get so afraid that you can't do something. You just monitor these things a little more. So this is a little more intensive. Their home daily weights, which he already knew. He's home monitoring his PT-INR, which is the blood thinner. Over a year, he lost 44 pounds from 313 to 269. His exercise tolerance has improved. His insulin requirement decreased from 100 units a day to 45 units a day. People ask, oh, but your kidneys, what about the kidneys? His creatinine, a measure of kidney function, improved from 1.8 to 1.5. The lower the better in terms of the creatinine. And his most recent left ventricular ejection fraction is 40%. He came back just a few weeks ago, one reason I brought this here, and he said, you know, Doc, they're thinking about an explant program, the starting one. And what they're going to do is they're going to put me in the hospital, and they're going to turn off the pump and see how I do. And then they might even take out the LVAD, the heart assist device. Wow. So we now have about a dozen folks with LVADs. Some we've sent on to heart transplant. Some who are feeling so well they're thinking about just leaving the LVAD in and not doing the transplant, because the transplant is no cakewalk. I mean, it's a big deal. You're on anti-rejection meds afterwards and all. But so there's even consideration now of the LVAD being removed. Essentially, this would have been, if this all goes according to plan, and he does great, that basically his heart failure, which was, he's on death's door, he got abridged to get on the low-carb diet, which is this ventricular device. He's lost weight, and maybe the low carbs, the ketones, we don't know, help things, and what a save, huh? You know? What about other clinical frontiers? And how is the world changing? Using fat for fuel has not been thought of in most medical research labs, even now. Using fat instead of carbohydrate as the primary fuel in the body. McArdle disease is a rare disease of skeletal muscle metabolism that prevents the stored muscle glycogen from being converted to glucose. So the idea was, we'll wake children up at night and feed them sugar all day long. And put in things into the tube feeding and everything so they get sugar all day long because their muscles can't store sugar. Well, someone, and I don't quite know who, I think it was a patient, thought, well, wait a minute, nutritional ketosis changes the muscle fuel from sugar to fatty acids and ketones, and muscles can do just fine on fatty acids and ketones. So it might even allow better function. So at Low Carb USA, about a year and a half ago, several individuals came up in front, told their stories, and Stacy Reason, Dr. Reason, tracked them down. It was kind of an international effort to get the data, the proof that they had McArdles genetically, and we now have published in a journal called the Journal of Rare Disorders and Diagnostic Therapy 3 patients, a 12-year-old female, 45-year-old female, and a 54-year-old male with diagnosed, proven McArdle disease following a ketogenic diet over 6 months, and they'd had better improvement in activity and exercise tolerance, lower muscle creatine kinase levels, which is just, nobody knew what to do with these people, and they are just very thrilled to have this happen. In fact, one of the mothers of the 12-year-old, is just like, he just wants to tell the world about this. The the daughter went from wheelchair to running with her friends in just a matter of a couple weeks. So, so don't underestimate what a ketogenic or nutritional ketosis kind of diet can do. And even in the face of skepticism or a doctor telling you not to, a lot of the times it's based on this false belief that we have to eat carbohydrates, we have to have sugars and all that, and consider, at least at first in a research setting, using nutritional ketosis or this kind of diet. I want to end on two things. One is a good news, and another, or one's a bad news, one's a good news. I want to say this in a way that's very serious. This is a clinical alert. These medicines called sodium glucose cotransporter 2 inhibitors are a novel class of anti-hyperglycemic agents that inhibit glucose uptake in the kidney. They're very effective for lowering the blood sugar. However, they also have known and documented risk of normoglycemic, meaning the blood sugar is normal, and yet people get ketoacidosis. And it can happen on any diet, including a keto diet, but including people who are eating carbohydrates. At the Duke Clinic, we've already seen 2 cases of SGLT2 inhibitor-induced ketoacidosis in people following a low-carb diet, and the degree of acidosis was life-threatening. The calls I don't want to get. Doc, I was in the ICU. My bicarbonate was 7. My pH was 7.2. These are, so stop SGLT2 inhibitors, please, when initiating a ketogenic diet. And I've already talked about this informally at meetings. Other doctors are hearing this. We have on the clinic, the TV going, there's a class action lawsuit already to call about if you've had a problem with these drugs. This is not a good idea. So in the literature, sticking to the literature, it's Hayami et al. In 2015 first reported this of SGLT2 inhibitor in a patient with diabetes and a low-carb diet. So be very careful with these medicines on a keto low-carb diet. The good news, I'll end on, is you can cite a national algorithm guideline that has low-carb diets in it. This is downloadable from the obesityalgorithm.org. It's the algorithm from the Obesity Medicine Association. And you can see in the circle here, in the nutritional guidelines, you can use low-calorie diets that are restricted in fat or restricted in carbs, and a very low carbohydrate diet, less than 50 grams per day, with or without nutritional ketosis, is in the guideline accepted by a national organization in the US. So look at this, cite this, say you're not the first one, and there are actually organizations that are recommending the use of this kind of diet for treatment of obesity and actually other conditions as well. Thank you so much for your attention.